Hello, everybody. Welcome again to another edition of the MCHD Paramedic Podcast. This is Dr. Kelcie Patrick, and we have a special guest here on our program today. I guess a repeat guest, one of our district chiefs here at MCHD. In fact, our newest district chief, Kelcie Adams.
Hello.
And, you know, from my perspective as an EMS medical director and really an EM physician in general, there's not much more valuable from a clinician growth standpoint than case discussions, debriefs, after the fact, talking it over with your superior. If it's one of our crews here at MCHD and Chief Adams, or if it's myself and, you know, one of my medical directors in the emergency department or one of my mentors. And these they're super valuable from my standpoint. And at MCHD, these take the form of clinical run reviews. And one of the sticking points for me really since I've been here is that these overwhelmingly terrify our folks. And so today, Chief Adams and I are going to try to flip the script a little bit and get down to the benefits and the business of introspection. So thanks again for joining us, Kelcie. Let's start with an introduction because since you were on last time, your role has changed here at MCHD. And for the folks who haven't listened to Kelcie's past podcast, tell the listeners who you are, how long you've been here, and the role you serve here at MCHD.
Sure. So my name is Kelcie Adams. Like Dr. Patrick said, I recently promoted to district chief. My prior podcast, when I was a guest on that episode, I was a captain at the time, and I was writing up in the district chief role. So it's kind of cool to look back and see the progress. This case we're going to discuss is it's a little bit ago when I was a captain, but it is a very impactful case for me and a lot of the lessons I have taken and implemented in my current role. But I have been here 8 years, and I've been a district chief for probably like 3 months.
And this is one of those times when you suggest something, you always have to think about the worst case that can occur when you suggest something. And so Chief Adams sent me an email. She was in my office reading my whiteboard of ideas, and one of those ideas was to discuss case reviews and run reviews and try to come up with through lines, common themes, things that we see in those run reviews as the clinical staff, as a medical director. And I immediately thought of this specific case that we reviewed with Kelcie because it was so impactful for her in the moment. But also, we've discussed it together as she's advanced here at MCHD in conjunction, in line with so many other run reviews that she's had as the leader on the call. So the topics that we're going to discuss are specific to this case, but they occur in so many clinical scenarios and situations, and we look back and say, man, I could have done a little better. I have several of these similar cases in my own memory bank, in my wisdom bank as an emergency doctor as well. So walk us through, Kelcie, the generalities of this case. Obviously, we are not going to discuss specifics, but the generalities of what you found on scene and some of the lessons that you learned within this. And we'll talk about some additional points with this as a jumping off.
Sure. So the call came out, I think it was 3 a.m. It was very early into the morning. We do 24-hour shifts, so fatigue levels were high. We had run a critical call prior to this one, and I think the call just came out as something very generic, like a sick person. When we arrived, we were pretty blindsided. There was a language barrier. The patient was critically ill, peri-arrest almost. Blood pressure was terrible. Oxygen saturation, also not good. Altered mental status to the point of almost being unresponsive. They had a lot of work that we had to do, and we were just kind of put in a chaotic situation from the get-go because we didn't anticipate this patient being what they were. We noticed right off the bat we would have to secure the airway. They required suctioning. They weren't breathing adequately. But we were pretty far away from meeting those DSI hard stops and those parameters that MCHD has set in place for us. I think my first mistake was confusing the overall objective, which was to transport the patient and be able to oxygenate them and attempt to stabilize. And I confused that with the procedure that I wanted to do in order to accomplish that. And stressful times and kind of just a lapse in cognitive functioning in general, you can have kind of like a time distortion. It just kind of gets away from you, and it can feel like 20 minutes and it's been like an hour and 10 minutes. Ultimately, we couldn't meet those parameters after pressors and fluids and multiple different types of resuscitative efforts to try to get the blood pressure above 90, maintain the SATs above 94. We would make hardly any progress at all. We were getting further away from our objective. Ultimately, when the district chief arrived, they were also pretty fatigued and they didn't have a good day. They had run probably 2 cardiac arrests prior to this one, although this wasn't a cardiac arrest, but they had run 2 cardiac arrests, and then they had to show up to this call. When they arrived, they've also kind of got sucked into okay, let's try to intubate, because that's the story I was telling them about why the patient needed it and why I was trying to do it. But ultimately, we finally just decided to use the iGel, which worked perfectly fine to meet the objective, which was to oxygenate the patient and transport safely. So the biggest takeaway on this one was the focus in the wrong area of focusing on achieving a procedure as opposed to achieving the overall objective, and getting tunnel vision based on trying to just get the procedure done versus seeing the overall picture of what we are trying to do with that specific procedure.
So you said a couple things there I want to sort of talk about in more detail, and also remembered a facet of this case that I do believe is worth talking about on the discussion. So it's not on the notes here, but you'll remember, and we can wing it. But
yeah.
You said that you were focused on the wrong things, and I believe so many times when we do run reviews and we do clinical case reviews, whatever you call them in your service, whenever I look at my cases in the rear view mirror, we say words like wrong. And thinking about this, put medical director hat on, you were focused on trying to oxygenate, resuscitate, and intubate the patient. Those aren't the wrong things. So I believe the terminology we use sometimes from the get-go sort of is kicking ourselves in the teeth a little bit. When you weren't focused on the wrong things, you just were in a bit of tunnel vision, and tunnel vision kept coming up in this case discussion. It comes up in so many of our conversations, and you use the term time distortion. That's true. And realistically, that was how this case hit our radar, was the fact that you were on scene for an excessive period, what we all would agree was too long. Mm-hmm. And it was really sort of that back and forth with blood pressure, that back and forth with oxygenation.
Yep.
And when we are in the moment, it feels so, I always feel constricted.
Yeah.
Like somebody's tying my arms to my body, and I can't really talk, and I can't really breathe, and I've got this one thing that's going to break me loose from those chains.
Yes.
And like you said, you're focusing on the procedure and not the overall patient goals. But your procedure is not wrong or bad. It's just sometimes we have to be able to pull the ripcord on our parachute, and recognizing that is pretty tough. Talk about the difference in the moment for you when you're thinking about these decisions versus sort of that aha moment that occurs when we're sitting down, and we usually do our case reviews here at MCHD in room 101. Everybody's scared to death of 101, but we're sitting in this random, nondescript, harmless room. And it's always so impactful for me as the person listening and trying to put myself in the shoes of the paramedics the best I can and think about what would I do clinically. Inevitably, everyone sort of has that eyebrow raised aha moment. Mm-hmm. So talk about the difference in tunnel vision in the moment versus sort of feeling it and seeing it when we discuss it after the fact, and how both of those intertwine with each other and that aha being valuable, and it allows you to reflect on that case better. Talk through that and how you've felt in the past when we've had those discussions.
Sure. So I see the case reviews almost kind of like a completed puzzle versus when we're in the moment in the call, we just have multiple different pieces that we haven't seen how they fit together yet. When the screen is in front of you and you're seeing all the data, so the vitals, you're seeing all of them all at once. You're seeing your patient contact time versus your transport time. You see the entire picture during the case review, and sometimes it's almost unbelievable because especially that scene time, sometimes you're looking at it and you're just like, whoa, it felt like 20 minutes.
You got the wrong truck? Are you sure?
Yeah, exactly.
I've had medics definitely give me that look like, I was on medic 20. Is this med? And of course, the medics aren't used to looking at the paper chart that we print because you see everything on the screen. And so when the chart's printed, it's not obvious what medic it is. And they'll look and be like, this was me?
Yeah.
And listen, I've been there before with, do you know how long it took you to activate a STEMI? Well, yeah, it took me 3 minutes. No. And then you think about, oh, yeah, I did have that conversation. And I printed a second one. And I looked at their old records. Oh. And you start to add it together and you realize, oh, that was longer than 3 minutes. So we all are there. It's not perceived. That's the hard part about tunnel vision is I don't believe that we perceive it. And then we get, the more constricted I get, the more, almost counterintuitively, the more perfectionist I become. So perfection
100%.
really becomes the enemy of good. And the value in the run review is that we're in a safe space. We're in a peer review protected space. We can say and talk about whatever we want, and the consequences are only personal and clinical growth. That's the only thing we're going to get out of that. Now, putting our ego aside, that's the only thing we get, but our feelings get hurt. We get defensive. We don't like to admit that we're out of focus, that we're out of control. That doesn't feel good for anyone, but you can take that pain in the short term for tons of gain in the long term with your clinical growth and your clinical wisdom. Because like Chief Adams said, the goal of these situations is never a singular procedure, or I should say rarely. Somebody out there could say, well, they've got really bad angioedema, doc. The goal is a surgical airway, and that's the only way we can. Yes, I get it. But very, very rarely is there a singular procedural goal. Our goal is stable transport, and it's oxygenation, it's ventilation, it's hemodynamic support. And that's where, especially when managing an airway in a critically ill patient, it's not a singular multiple choice question. There are multiple answers, some more right than others, but it also has to be taken into context with the scene, with the time, with our cognitive load, with the number of hands that we have on scene, how much help do we have, how far away are we? All those things play a role. You mentioned it before. I think it's worth hitting on in this discussion. We, as clinical leadership, me as the medical director, when I read the chart, I'm trying to recreate a picture of what's going on. So I use things like scene time, the timestamps for our procedures and our meds, the vital sign progression. What did you get dispatched to? Because if you get dispatched to a nondescript, especially non-lights and sirens response, then maybe you walk in and you're a little blindsided. That's no difference in the ER if I'm triaged to a toe pain and I go in and they've got raging cellulitis and blisters up their leg with erythema to their hip and a fever and tachycardia and hypotension. Well, I got undersold. That was septic shock, not toe pain. That was necrotizing fasciitis, for example. So in this situation, there was a real quick spot where I knew you all were in a bit of a behind the eight ball situation, and it was 3 a.m. And you may or may not believe this out there, listeners, but we actually looked at what your day had been like. How many calls had Kelcie ran? And it was a lot. So multiple calls over 24 hours, 3 a.m. As we reviewed the call, the district chief at the time said, yeah, this was my third call in a row. The past 2 were arrests. So she was overloaded as well. So what are some things that you can do in the moment that can fight fatigue? Because we can't cure it. It's a part of our job. What do you do in your role to try to fight fatigue? And this isn't a podcast on fatigue, but for those of you out there who still believe that run reviews involve corporal punishment, we really are just trying to see and get into the mind of the crew so we can educate better, so we can create a better system. Fatigue played a role here. What are some of your fatigue tips? What do you tell your mentees about fatigue, new employees, your in-charge candidates? How do you fight it? What are your suggestions?
Well, the very basic things that we should just have as a baseline would be, just making sure we're hydrating throughout the shift, eating as well as we can. I know sometimes that's not an option, but for me personally, I think the number one thing that saves me a lot of times is just building good habits. And sometimes I do not know where a gap is, where a habit needs to be formed. During this call, I did not know I was fatigued until after it. So that's part of the problem too. Is sometimes you don't always know that your cognitive functioning is not up to your normal baseline. So habits help me as a safety net. So whenever I don't understand that I am having a lapse or I am getting tunnel vision, I can revert back to my habits that are there, whether the call is going well or it's not. It has to be practiced all the time. And the habit I took away from this one is when I say, we will voice DSI in progress to alarm, and at that point I already have a 20-minute timer set on my phone, and I will start it. And once that counts down and it goes off, I have a chance to regroup, and instead of waiting till a case review to see the whole puzzle put together, I can kind of have a second to take a step back and see how much of the puzzle I have already put together. Am I closer to meeting the objective? Am I focused on the wrong thing? And then that's kind of like my little reset button, and a chance to kind of communicate to everyone, like, okay, so right now we're at 20 minutes. Haven't been able to get the blood pressure up. We're 20 minutes from the hospital. What do you guys think about an iGel? And if everybody's on board with that plan, that's the plan we implement, as opposed to having no kind of check mark in place of how long have we been trying to do this. And that has helped a lot, especially in my current role when I arrive on scene, because you can arrive on scene as a district chief and feel like, oh, this is the beginning of the call. Like, no, it's not. They've been here for 30 minutes.
That's a really excellent sort of description of, I'll take that in pieces. We don't often know we're tired when we're tired. Mm-hmm. When I can recognize it on my shift, when I get to 4 a.m. and I start the malignant yawns, I use that as a cue, not in exactly the same way as you described, but I think to myself, just be cautious, don't miss, be thorough. Mm-hmm. And so I use it as a cue to, like you, use my framework, but also just when I feel it, I just admit it to myself. I think a big portion of fatigue is awareness, and if you're not consciously thinking about where you're at on that scale, it can't escape us. So I just remind myself, like, you're tired, be thorough. You're tired, be thorough. You're tired, use your foundations. And I just admit it to myself, almost say it out loud as a mantra sometimes to try to get through that, for me, which danger zone is usually 3 a.m. to 7 a.m., sort of the end of the night shift, mm-hmm. where I know that it's a pitfall. You also said something there that sort of led into my next question, almost answered it, and that is, what happened after this run review, and what changes have you made in your practice and teaching due to this experience? And you put a timer on yourself. Mm-hmm. I did that in my own practice after listening to these run reviews. I did not do that probably 2020. I mean, this is an actual thing that I do in my own practice because I've learned from y'all. And it's made me a better ER doctor 1,000 times over. And that is, I am very intentional about timers with my nurses, with my own phone and my own self. Y'all bring me a patient that's on BiPAP and struggling. Well, how long do I give them? Mm-hmm. Well, I don't let that be nebulous anymore. I say to myself, and I say to the nurses, I say to the respiratory therapists, hey, we're going to reassess this patient and it depends on the situation. If they're in an extremis, maybe the time's shorter. If they're on the fence, maybe the time's a little longer. The point's not the exact time period. Kelcie's is 20 minutes. That's because of the role that she has here at MCHD. And I don't want us to misunderstand. No one's changing protocols here today.
Right.
The idea is that when you arrive on scene and decide to make a decision to move forward with any procedure or any resuscitative framework, whether it's rule of 15s, whether we're talking about snores, whether we're doing a delayed sequence intubation, it can be even simple stuff. How many IV attempts are we going to take? The idea being is that if we say it out loud to our team and we close loop communicate that, it makes us less likely to fall in that nebulous tunnel vision sort of time distortion, because we've set an alarm on our phone. We've said it out loud, whether you say it to dispatch, like Kelcie mentioned, or you say it to your nurse like I would do in my practice. It's all the same process, and that is using your own verbalization and your team to pull you out of that time distortion.
Yeah.
Have you found that that's worked for you? Have you found times since this review that your time clock has went off and it's snapped you out of it?
Oh, 100%. Yes. And I'm thinking, like, it didn't feel like that it was 20 minutes. It felt like 2. And it was like, oh my gosh, if I would have thought that was 2 minutes, I would have been here an hour thinking we've been here 10.
So it's not about the time period. It's just about the staying conscious and using that external clue, that external alarm, using for me, my nurses, my RTs. I'm going to give this patient 20 minutes on BiPAP. I want you to get me a VBG in 20 minutes, please, and let's reassess. And I'll go enter the VBG order for 20 minutes later. And that way I can go see patient 2 and patient 3, and I know the RT is going to come back and do his or her job, hand me that VBG sheet, and I'm going to be forced to go say, all right, what did the PCO2 do? Let's go look at the patient, because it's always a patient and a number, and that's going to be my clue to not let that 20 minutes, like Kelcie said, turn into an hour or longer, because it happens to me in my practice as well. I made you ask me one question because this was a setup question. We didn't set up any of these except for this last one, but I did want to talk a little bit about the fear that exists behind these. So what's my one question from you, Chief? And that's really the one that's, I want to try to dispel some myths here a little bit.
Well, the case reviews. So when you're asking about what do you wish the medics knew about case reviews, there's no violence.
There's no violence.
Yep.
There's no violence, everyone. No one gets beat up. I want everyone to know also that when we look at these cases, when I look at them from an oversight standpoint, yes, I know from your perspective, you come, you sit in the chair in 101, you're across from the medical director, and you feel like that the spotlights are where?
Right on you, probably like under your chin almost.
Yeah, you're like the French fries at McDonald's. You're under the heat lamp, and I promise you that before y'all sit down in 101, the spotlight doesn't go on you first. I put it on me. I put it on our system. I put it on our protocols. I put it on our education, on the rest of the clinical department. Where did we screw up to put you in that position? And I've thought of this more recently as you're being asked to juggle. You're jugglers. You're clinical jugglers. You juggle so many balls in a case like this. Language barrier, middle of the night, way out in the periphery of the county.
Yeah.
Critically ill, hypotensive, hypoxic. I mean, there's how many balls? We're at 10 balls probably. And we often use the term mistake or wrong. I don't like either of those, because your heart was in the right place. You were trying the best for this patient. Even proceeding to intubation wasn't a wrong decision. Your focus just got distorted. So I think about it as juggling and dropping balls. And the ball got dropped in this case. You dropped the ball. Yep. We learned about that. We talked about it. But sometimes the education wasn't there. So you didn't drop a ball because any other reason. I didn't explain to you well enough how to juggle. That's not your fault. What if our truck is stocked inappropriately or our protocol is unclear? Well, then maybe I've tied your right hand behind your back and said, go ahead, Kelcie, juggle with just your left hand. Well, I am actually a juggler. I can juggle a little bit. I used to be able to juggle pretty well one-handed. I can't anymore. But it's way harder to juggle with one hand than it is with two. So I have to give you good instructions. We as MCHD have to give you good instructions. We have to make sure that both your hands are free, that we've not tied your hands behind your back. So those are the two questions that I ask myself before we talk about the ball dropping being at all the medic's fault. And in that situation, it's not even about fault. It's about where do you have a deficiency, and then where can we educate? And so in this situation, I don't know that there was anything to our education than just being thoughtful and being presented, because 99 times out of 100, when we have these run reviews and we put that puzzle together that Kelcie talked about, right? And the puzzle is the monitor data. The puzzle is the vital signs. It's the timestamps. It's the whole picture in a safe, calm environment. I don't need to explain anything. Y'all are your hardest critics. So many times you've already debriefed the call with your district chief anyways. Our last several run reviews together, you've done 90% of my job because you've already reviewed the calls with our crews. And so we just reinforce that and reaffirm that. And which leads me to my last point, and that is perfection in medicine, especially emergency medicine, especially in pre-hospital emergency medicine, where you have so many balls and it's so hard to juggle them all with not a lot of help and not a lot of time and zero information and all of the austere pieces to being a medic in Montgomery County or anywhere.
Yeah.
If we want you to do it perfectly, exactly, precisely the way that I would do it as the medical director, well, that's insanity. So it's not about perfection, it's about thoughtfulness. And in the end, 990 times out of 999 out of 1,000 here at MCHD, we're thoughtful. We're out there trying our best. That doesn't mean we can't misapply principles. That doesn't mean we can't misapply protocols, misinterpret data, suffer from thought distortion. All those things happen. But when the thoughtfulness is there, that's that error of the mind that occurs. It's our job to remediate that, ensuring, and I'm telling y'all now listening, we've put the mirror on ourselves first and said, bad protocol, bad education, bad system setup, system design. Nope. Okay, well, let's talk to the medic about what happened and get the story. And then sometimes the story is, there was a pit bull biting at my leg and the mother had dementia and she was burning herself on the kitchen stove and we had to get out of there. And like, okay, I guess I can see why you didn't put moves in place.
Yeah.
We had that literal run review. And
Wow.
so sometimes the run review is the rest of the story. Now that may lead to maybe a little better documentation.
Yeah.
That may be the end of that one. But I want everyone listening to know that we can't get better as a service, and you can't get better as a medic. I can't get better as a medical director if we don't learn from our own cases. So that's the purpose of looking in this rearview mirror that we're doing on this podcast today. I believe we may have other similar run reviews to discuss in the future. I'm not sure I'm ready to commit fully to a series here, but I really do appreciate Chief Adams bringing this up. Hopefully this discussion mirrors and reaffirms some of your own experience out there as a listener taking care of patients. It's something that I do in my ED practice every single month as I look back, think about places where I screwed up and how I can learn from them. Wisdom is time and reflection on your experience. If you just work for a long time and you never reflect on where you can improve, you don't really gain wisdom. And we've talked about that a lot on the podcast, and I think I'll leave it there. Anything you want to add before we wrap up, Kelcie?
No, I like the ending, the way you said that. And just the biggest, I think one of the phrases you've said to me that's kind of always stuck is just don't let perfect be the enemy of the good. And I think when you speak with the case reviews, whether it's my own case or someone else's case that I was the district chief on, I've never been in a case review where it wasn't both sides trying to determine inadequacies, and it wasn't blame on, well, you're more inadequate than me. It was just, hey, where's our gaps and how do we fix them? As well as you could read the run review, but I've never seen you or anyone else in that room assume. You always start with what was your thought process, and you hear them out. And I think it's maybe kind of uncomfortable, but there's just, it's that education you get from it is just priceless.
It really is. To me, it's like a form of mental workout. I don't love doing squats, but I also, as I get older, I like the ability to go up and down stairs and not fall. And I believe for us practicing emergency medicine, I don't love critiquing my own inadequacies, my own juggling drops, whatever you want to call them. But it's better in the long term than continuing to make the same flubs over and over again. And it's the only way to get there. So I believe what you're saying is there's short-term pain for long-term gain.
100%.
And in the end, we try to set this up so that it's a net positive. And I tell folks that when they come in for their first, if you go through your whole career here at MCHD and you don't have a run review, I don't know that it's because you're perfect. It's probably because your medical director is not looking quite hard enough. So as always, thank you all for listening out there. Please follow us wherever you listen or watch, on YouTube or on your favorite podcast platform. If you have questions or ideas for future podcast at mchd-tx.org. We'll listen and try to get your idea on the list as soon as we can. Thanks again, Chief Adams, for joining us. We appreciate your input. As always, thanks for listening. We'll be back with a new episode soon.